Welcome to the Low Carb Conferences podcast. I'm your host and founder, Dr. Jeff Gerber. Today, our special guest is Peter Cummings, who's the founder and director at Restore Medical Fitness Center and also a sponsor of our Low Carb Conferences YouTube channel. So how's it going today, Peter?
Going great.
Well, it's great to have you. So let's tell the audience a little bit more about you. Peter's company, Restore Medical Fitness Center, offers remote coaching programs called Get Healthy to clients, patients, providers, and employers. He has been working in the field for 30 years, specializing in preventive health and human performance. As an endurance sports coach, he has helped athletes achieve their personal performance goals, as well as helping others to maintain good health and well-being. Peter's research is now published in the medical literature looking at insulin resistance, low-carb diets, and exercise. Having worked with Peter, I can tell you he's intelligent, passionate, data-driven, caring, and quite generous of his time and money. So with that, Peter, if you can tell us some more about you, including your background, passions, research, business endeavors, and anything else you want to discuss.
Well, thanks, Jeff. That was kind. I am very passionate about this field of work. I strayed away from considering practicing medicine or the medical field many years ago due to the fact that I recognized that there was just such a focus on illness care and the use of pharmaceuticals, even 30 years ago. And I saw this through the lens of being a family member of an aging set of grandparents that had diabetes, and I just listened to what was being told to them. Back then, eating their cucciatari cookies and their Italian bread and just taking more insulin was par for the course, and it was troubling to me. And the more I saw that and what medicine was, I realized I didn't want to be a part of it, which left me in a conundrum where I kind of had to figure out what it was that I wanted to do. And I have a very good science background. I'm very interested in science and human performance and biochemistry and biomarkers and fitness and all these things. And that's where I put my energy into, was a lot of the same things I was learning in college. I was able to apply to more of a preventative and restorative model. Back in the late 80s, though, the only person that we knew that went to gyms was Jane Fonda and Arnold Schwarzenegger. And I realized that wasn't necessarily how I envisioned myself working with people. So I endeavored to actually develop a medical fitness model that had exercise and lifestyle modification central to the treatment protocols. And that's what led us to the journey to today, to Restore, where recently we were able to get away from our brick and mortar model. About 11 years ago, I met a cardiologist who just absolutely loved what I was doing, loved my vision of medical fitness and its application in healthcare. But one of the things he was really interested in was what I was doing with my athletes, where for 25 years I've been able to remotely program them, assess them, look at their daily routines, give them very quick feedback on what they were doing and redirecting their work. And he was a lover of telehealth. And he said, that's what I want for my medical fitness model. So I worked with him for 5 years, but unfortunately, back when the ACA came out, there was a lot of pressure on healthcare to make changes, and that small 14-doctor practice had to change. And one of the things that was going to be put to the curb was this medical fitness model that I had developed. At that point, I had been directing their cardiac rehab program as well. And I learned a lot from the cardiac rehab program about what was acceptable practices and level of professionalism. And when you think about what cardiac rehab is, it really is one of the few accepted lifestyle modification programs that are part of the healthcare continuum. So I was able to learn a lot from that model and applied it in our model. And And that's how we were able to produce all this data, because we knew outcomes were important. So we took the cardiac rehab model and really turned up the knob on looking at blood chemistry and fitness assessments and all these things. And that's what allowed me to finally publish after I met Tim Noakes. So I love the low carb community. I've been pushing towards a low carb nutritional pattern since I read Barry Sears' The Zone back in 95 or 6. And, when you think about what 40-30-30 is, it's more like the diet that we're eating before, the food pyramid and the agriculture industry and the food industry all took over. And that really helped a lot of our patients, but it wasn't helping the diabetics because it wasn't deep enough into therapeutic reduction. So I was taking all the courses, watching all of your videos out of Denver, and I just fell in love with the community and their passion to want to make a difference. And I was already there, and I kind of came out of my hole in Buffalo and really dove into what the Nutrition Network was offering as far as coursework. And when they came up with their medical practitioner course, I was a part of the first graduating class, and now I actually am a tutor for the last 2 years for that medical practitioner certification, and we are approaching the end of the third class. So we have 10 PhDs, MDs, dietitians that are all going through this upper level course, and this holiday week is when they have to do their writing. So they have a lot of work on their hands. They have to produce a peer-reviewed level type document to hand in, and then they have to be orally assessed. So I'm excited about being more involved with this community, and that's why my sponsorship, when you were looking for sponsorship for your videos, I was motivated to step up because I really love what this community stands for.
Peter, we really appreciate the contribution and the support that you've made with the community, and will continue to do so. As I said, you're really passionate and very generous of your time with the community. And back at you, we want to let the listeners know about you and what your services are. So it was great to hear your background in some more detail. And just to back up a little bit, so when you were working with the cardiologist, as you call it, brick and mortar, so you were doing that in-person coaching, am I correct?
Yeah, that's correct. I was with my athletes remotely. I have athletes coast to coast, but when it came down to the medical product, if you want to call it that, back in 2011, a lot of these remote physiologic monitoring devices really were not available, at least not in a HIPAA compliant standpoint. So there may have been blood pressure cuffs that people could take home, but there was no connection to the practitioner. So in the past 5 years, that has really changed. So I was preparing for that, but by the time this stuff started to really come to market, the medical practice had dissolved, and we were on our own. But we never gave up on the model because we really saw that we're capable. If you look at the healthcare industry or even the fitness industry, a lot of us live on an island. So the people that we service are within a certain diameter or distance from our practice. And this doctor believed in telehealth and meeting the patient where they were. As a cardiologist, he understood that one of the big barriers to cardiac rehabilitation is distance from a center. Also, the fact that they usually run between 8 and 4 Monday through Friday, where these people had to get back to work because they'd already used up their PTO. So not having hours available for them to come in when it was convenient, the distance that they had to travel, all these things were barriers. And I understood that, and understood that I was already delivering a product coast to coast, and in some cases never even meeting my athletes. So I realized, as he pointed out to me, that this was the future, and this knocks down the walls of my medical fitness center and enables us to deliver a world-class product right to the hand of anyone that's got a connected device. And that's what we're excited about.
Yeah, so this is what I want to ask a little bit more about. So obviously, the technology and the ability to share data and metrics back and forth through your app, and I'm sure through other means, that's the obvious part of it. But when I think about your services and your background, well, you're a sports and exercise coach mainly for endurance athletes, and I envision you standing next to your client
Yeah.
and coaching them. And that's what we see in the gym all the time. And how does that translate over to helping people remotely, giving them exercise programs and nutrition advice?
Well, when you think about it from a foundational standpoint, what you would do as a medical practitioner um, is a SOAP note, right? That's how you're starting your interaction with your patient. What is your subjective opinion and view of that patient as they sit there in front of you? What does the objective data tell you? What is your analysis or assessment of that patient overall, and what is the plan that you're going to put in place? So I had to think of this in a similar way: is how do I analyze a person's dietary pattern, their current dietary pattern, and then make proper recommendations based off of their biochemistry, biomarkers, and their personal goals. It's the same thing with exercises. How do I assess their cardiorespiratory fitness, and how do I assess their movement competency to ensure that if I'm going to load them with any type of resistance, even if it's body weight resistance, that I am not doing harm, right? Because some people's competencies are much lower than you would assume just by looking at them. So we developed a functional movement questionnaire that allows us to ask the patient to assess their own movement quality of 7 patterns. This gives us an idea of what the competency of that person is, and then we can direct correctional exercises and resistance workout through the technology that we have available. So we will create a personalized program and deliver it right to the app for the patient. And they have little videos that show them how to do the workout. And then they meet with their exercise physiologist, health coach, and diet coach regularly to get feedback on what they're doing. And then we're using apps like Chronometer, who's been a great partner to us, to allow us to see what the patient is doing on a regular basis nutritionally. The scales, the blood pressure cuffs, all these things allow us to monitor the data. So we get to see if the trajectory is changing. So much in the same way I would do it if they were in the room, I use the technology to put them in the room even though they're not in the room. So
So you can meet with them virtually.
Yep.
And actually
Just like you and I.
look
Yep.
at them moving. I mean, do you
Yep.
sometimes pull
Yep.
back on the camera and
Yep.
or show them an exercise?
Exactly. So I could do a 6-minute walk with them. They could do a 6-minute walk using some apps. From there, I can assess their cardiorespiratory fitness and say, okay, well, this is what's appropriate. I don't want you to work harder than this. I don't want you don't need to work more than this. This is how many days a week. This is how many minutes. Let's follow that program. And then that's delivered to them in an email every day. You're supposed to go for a 20-minute walk today. This is how hard the perceived exertion should be, things like that. And then they would get another email tomorrow that says, this is your resistance workout, and maybe a 10, 15-minute workout. And that's what some of these people need. They may be doing sit to stands as part of their routine. Obviously, there's people that are more advanced than that, but you have to be prepared for this other group of people, because many of the people that we're trying to help are highly deconditioned. Their movement competency is challenged. Their balance may be challenged.
Sure.
And overdoing it with these people it is a severe mistake. It's a professional mistake that contributes to their failure. And if they get hurt, they get burned out, they feel like they've failed, the odds of them sticking long term to this behavior is reducing every step of the way. Where if you can encourage them, give them feedback, great job, you did a 15-minute walk, keep up the good work. You did your routine, answer questions about the routine. If they say, well, that bothered my knees, taking a look and seeing how they're doing their sit to stand. Is it a knee dominant sit to stand, or are they using their hips? And teaching them a little bit. And a video like this can be all that they need to help stay on track.
Well, that's great. I mean, with the technology, it's really infinitely expandable. You just need enough staff to support. And as you say, some of your clients are very deconditioned and they might be afraid to go out, to go to the gym, to interact with people. So I think it's a great media, but I would just say, what about my gym bros? I love going to the gym and hanging out and interacting with them.
The social aspect is a big part of it, but not a lot of our people are ready for that. And I guess that's part of our goal, is to get them out and to do these types of things. And it doesn't matter if they're members at a Y, or they're a meathead and they like to go to a gym, and or they're a patient that needs, someone a companion to do their 15-minute walk. You have to be ready, and it has to be personalized, and it has to be appropriate. And because if it's not, like the 10,000 step thing that I constantly listen to, if you really do the math on that, if you understand the physiology, for many of these highly deconditioned patients, the people that you would see in your office in cardiac rehab and things like that, 10,000 steps is a recipe for overtraining for these people. It may be as little as 3,000 steps a day for these people. And if they were to do that, maybe next month it could be 5,000 steps. And the month after that, maybe you could get them to 10. But to just randomly or generically put out 10,000 steps as a goal, that may be a long-term goal, but it may not be appropriate for today. And that's what bothers me a lot about what I see out there, is not being the professionalism. And I think in a large part, that's why one of the reasons the medical community doesn't use it as much as maybe they should as a partner or a referral, is you got a lot of meatheads in gyms, and they may have no background in understanding first do no harm, or how to assess something like that, and what is appropriate for someone that's that deconditioned. Where with just a little bit of training, and I hire exercise physiologists to do this, but they understand that because they work with this wide range of people too. As trainers, we all like to work with an athlete that's highly motivated. It's fun. But you know what? Reversing diabetes and getting someone to be able to complete a 6-minute walk test is awfully exciting too. So
yeah. Well, I have a story. I have a patient, a woman in her 40s, that she decided she's going to start exercising. She went to the gym, had a trainer. After 2 days, she came to me. She couldn't walk. She could barely walk. She had pain in her quads that you would not believe. And it turned out she developed rhabdomyolysis in 2 days.
Overdid it.
Yeah, it was unbelievable. So, that to your point. But, if you can describe it, you get a spectrum of athletic individuals. And so on the one side, we're talking about, say, a diabetic that has weight to lose, improved metabolic health. And we might have talked about it, but Mark Cucuzzella, who's into fitness and exercise, brings up this point that the diabetics are so metabolically unhealthy that they get winded walking to the mailbox.
Yeah.
And
you know why?
Go ahead.
Well, when you really look at this, you step back and you look at the pattern that develops. If you look at my athletes and metabolically, what makes them so fit is their ability to oxidize fatty acids at higher rates of work is far superior than the average person. And compared to a patient, it's in a different world. Because when you look at the data, it shows that when RER at rest starts to go up, respiratory exchange ratio, when we're burning glucose at rest, then your fatty oxidation is compromised. And as soon as these people that are glycolytic dependent, if you want to look at it like that, begin to move, lactate levels go through the roof. It becomes extremely uncomfortable, just like it would for that athlete at the higher end of a ramp test or when they're doing intervals. And these people are basically getting a message from their body to stop doing that. And that's why I feel it's very important to use a therapeutic carbohydrate reduction approach with these patients, because you start to quickly see that the fatty oxidation increases as the insulin levels drop. And this is what gives these people who are not only deconditioned, but are glycolytic dependent, margin. And that little bit of margin to complete a 15-minute walk may be the difference between them sticking with it next week or 3 days or 6 days or whatever the case may be. And I think we fail to see that and understand that. And that's why a lot of times in this community, people who are unfamiliar with exercise, especially if it's not appropriate or are afraid somebody may be getting an inappropriate dose of exercise, they stay away from exercise as part of the prescription when using carb reduction. And it's like, well, wait a minute, this is like one of the best things people could do, especially because they're deconditioned. We should be encouraging that. We just need to understand it better. And that's where I think someone like my staff and I, come to the table and say, what's appropriate for a diabetic who's severely deconditioned? In fact, could be functionally dependent, for others to do shopping and yard work and things like that. They may have a fitness level that's so low, and that means that the therapeutic carb reduction can start giving them a little bit of margin, but don't let them overdo it at that point. But start getting a routine established. Put it all together, because that's what our lifestyle package should look like. It's a multidisciplinary approach. I just had one of the class people ask me that, one of my mentees, and you just don't know, right? It could be they are doing great with TCR, so they got a great carb reduction, they're dialed in, but they don't exercise, they have a stressful life, and they have terrible sleep. Or maybe it's just one of those, and the sleep is affecting their stress, their ability to recover from their exercise, and leading to bad behaviors nutritionally. So you have to look for the low-hanging fruit, because all of these pillars, the stress, the sleep, the nutrition, and the exercise, all have interplay. In fact, that was the document that the Nutrition Network just released. I published for them. They asked me to write something on exercise, stress, and sleep, and I highlighted the interplay between these things and how important it is if you're trying to address someone's health from a lifestyle perspective. You need to take a look at all these components and find out if they're dialed in marginally in the right direction.
So I'm just as frustrated as you when I hear people start to go down the path of healthy nutrition without addressing diet. And Gabrielle Lyon talks about musculocentric health, and the idea that skeletal muscle is an organ unto itself, and feeding that organ, making that organ healthy, improving mitochondrial health has to be addressed, because it works both ways. You improve your skeletal muscle function, you improve your metabolic health, and
Yes.
they're just absolutely tied together.
Yeah, I love what Dr. Lyon and Dr. Seaman and Tommy Wood and Ted Naiman and these doctors that understand how that lean muscle tissue is critical. And I have to say, that's the thing that I find most alarming about this GLP-1 receptor agonist push, is we're failing to recognize, if you look at the data, that the amount of lean muscle tissue loss using these medications is almost double the lean tissue loss in a low calorie diet. I think one of the studies showed a comparison with a 16-week, 860 calorie a day diet, where those people lost maybe 1 in 4 pounds was lean mass, where in comparison with the GLP-1 receptor agonist, we're talking about 44% of the weight loss was from lean mass. That is a long-term metabolic disaster waiting to happen. And I think we have to be really careful with the use of these medications. I think, like with bariatric surgery, we have to consider that lifestyle modification before, during, and after has to be a part of it. And we have to try and realize that we can't build a long-term dependency on these medications without serious consequences and risks.
Yeah, I told you we would have plenty to talk about, Peter. I didn't think we would be going down the GLP-1 rabbit hole, but that's certainly a great topic that we can talk a little bit more about. And for our audience, we're talking about all these medications that are the rage the past 2 years. Everybody from Hollywood has to get a hold of them, and they include medications like Ozempic, Wegovy, Mounjaro, and there's newer ones coming out. And just to share my thoughts about it, firstly, the class of medication has been around since 2005. Actually, Byetta was the first one. And it's quite interesting because it helps metabolism in many ways. and it decreases appetite. And just people don't know that the drugs were around for the past 20 years, but again, they've become popular in the recent years because they're more powerful. And I agree with a lot of what you said. You have to be really careful about how and who you prescribe the medication to. And in our community, it's very polarized in terms of whether you like the medication or you don't like the medication. And I'm a guy that always tries to find common ground. And, the way that we deal with the GLP-1 medication in our office is that we're very careful and cautious in terms of who we recommend the medication to. For instance, if someone is really struggling and just not making any gains, and the contingency is that, okay, well, we can think about using this medication, but you must stick with an appropriate diet. You must get out and exercise and move, and we're going to watch you really carefully. So that's kind of our point on that.
That's one of my critiques, is that I think too often when you look at this medication and many others and procedures, that there's no real effort being made on the lifestyle modification side. It's almost superficial. And without giving the person a fair shake at these other things, the right support, the right guidance, the right tools, then you can never really say that, oh, lifestyle doesn't work. Like that's been one of the big things in the community. Oh, lifestyle doesn't work. It's too hard. It's like, well, it's too hard when you give bad advice, because bad advice gets no results, and efforts that get no results are always dropped by the wayside. And without the right support, without the right guidance towards exercise, for instance, you could have people that tried it and get rhabdomyolysis rather than got stronger and more self-sufficient. And I think as long as we get a full court pressure on these other things that are foundational to health, if a medication is needed, that makes sense to me. I also think that not a lot of people understand that incretin hormone is also produced naturally in the body by eating a whole, unprocessed diet, and you can trigger a lot of those same things. And a lot of these people actually may be suffering from a chronic exposure to ultra-processed foods. But we'll wait for the data to come in on that.
Yeah, good point. Well, I had a patient come in, and of course he wanted to get one of these new GLP-1 medications, and he said, so I understand that it's a metabolism booster. And I said, no, it's quite the opposite. It's actually catabolic. It takes away your appetite. It eats away at your body, both muscle and lean muscle and fat. And so, yes, you might be a candidate for it, but the caveats are we're going to measure your body composition really carefully, and we're going to make sure that you're moving and being active and working muscles, or you're not going to get this medication.
I have to say this is a topic of discussion in the self-funded market. So I'm sure you understand it. At some level, these employers have taken on risk. And what they're saying is, we'll direct contract with the networks that we want, and we'll pay cash, and we'll get a discount for that. And this whole GLP-1 RA medication thing, as you know, is quite expensive. And there's a lot of people that want weight loss, and they were ill-prepared for the surge in spending that they were seeing. So a lot of these employers who have been self-funded for a while really saw this as a shock. It came on as a surprise, a wave of spending, and they're looking for answers. And that's one of the things that we tell them is, much like bariatric surgery, there should be some precursor to beginning to use that. Are the people doing the other things correctly before we just willy-nilly spend $7,000+ annually on a medication that, as all medications do, have some risk and some side effects? So we're glad to be able to offer an answer to say, well, we're highly effective at fixing metabolic issues and weight and weight is one of them. And the only side effect they have is a better quality of life. They're more physically and mentally happy, engaged, and there's just not the same side effect. And our cost for a 1-year program is less than a third of this medication. So we're excited in answering questions and solving problems for employers, self-funded employers that are looking for answers to deliver to their population.
Yeah. So talking about that a little bit more. So yeah, certainly instead of spending money, millions of dollars on these medications, address lifestyle, diet, and exercise. And again, as you say, you're now approaching employers, self-funded employers. You're actually going to healthcare providers and reaching out to their patients with your program. And I love that. We have employers in town. In fact, Lockheed Martin is actually has set standards nationally in terms of their wellness and prevention program, and the basis of their dietary advice is paleo or low carb. For years, and we've had a good relationship. But how do you kind of get in the face of healthcare professionals and employers to offer those services?
Well, you can reach out directly to them, but in their HR departments, this time of year is kind of rough. They're awfully busy trying to figure out next year's packages. But the brokers, the captive coordinators, the third-party administrators, people are looking for answers. And unfortunately, there's not a lot of good answers out there because a lot of the stuff that's out there is rubbish. When I pointed out to one of the brokers that, their own education was on hypertension was salt reduction, salt reduction, salt reduction, and salt reduction, and take your medication. And pointed out that's not going to change anything. That's not going to change the cost. It's not going to change the fact that they're hypertensive. And it's not addressing what is more than likely the root cause of the majority of the hypertension, which is the insulin resistance. And you try to educate them and get them to get you in front of the employer to make a decision it's a little bit more proactive and outcome based. That's another thing because of the way we've basically built our model. We have the data to prove because we track all that stuff as far as medication cost, medication utilization, and normalization of these conditions, to show that there's bang for the buck. There is ROI, where that other advice of eat less sodium and take your medications is really never going to show up on the ROI scale. So we're excited about that market, and we're also excited about the primary care physicians who are looking for answers to help them with their patients. The primary care guy and the low man on the pole in healthcare, who's absolutely critical for population health, has limited time, tons of work, and until recently has not really had the resources available to even address these issues. How many primary care doctors have a exercise physiologist, health coach, dietitian, reaching out to patients on a regular basis as a majority of their job, like my staff can do? So we're capable of contracting as auxiliary clinical staff and supporting the patient with chronic disease through an RPM billing. So the provider is the medical supervision, and my staff delivers the making sure that the patient takes their blood pressure most days of the month, gets on the scale, takes their glucose, and then gives them feedback so that if they're outside of ranges or they're not eating correctly, and try to coach them, not only just monitor them, not just to watch what happens to their blood pressure or their weight or their glucose, but actually coach them like we do in our program towards better outcomes. And the next time that primary care doctor sees that patient, as David Unwin's story goes, I didn't recognize the patient, and it had nothing to do with what I told them. I just love that story from him. What motivated him towards this community was his patients and their self-found outcomes,
Yeah, that's great. Well, as a primary care doctor, as a family doctor, I certainly appreciate what you do, and my patients are a little bit more educated, and so I refer them to you and to other groups that are doing what you're doing, and I understand the importance. And this kind of ties into what you said previously. You'd mentioned that insurance will pay for cardiac rehab once the patients had the widowmaker, but they didn't die, right?
Yeah.
They kind of pay for prevention, if you want to call it that, when it's end stage. And this goes with with you can't counsel a diabetic unless they have end stage renal disease. It's really frustrating,
Yes.
and so the same is with your programs. I can refer people to your programs, but insurance won't cover it. They have to pay out of pocket, and that's so wrong in every way.
Yeah. Yeah, and that was one of the things, again, that my mentor and as a cardiologist, the CMO there, really taught me is not only these barriers, but the inequity and things like that. Not everyone has the money for our program. That's another thing I didn't mention, but when we did our face-to-face program, because of the cost of the facility and all that other stuff, our program cost was about $350 a month, and we never changed the price in 12 years. It never went up. But at the same time, $350 a year for many people is they're just incapable of doing that. So we're capable of delivering the exact same product with similar outcomes at $150 a month. Now, while that is still unreachable for many people, for the employers and for the payers, it starts to become a number that's making a little bit more sense. I have to say that, he made a big impact on me regarding trying to keep the cost down, the convenience high, and really focusing on the outcomes. And that's what we've been able to do. We have patients in Wyoming from a physician that referred to us that reversed their diabetes, reversed their prediabetes. And again, we've never met these people. It's all been just like with you and I. So good advice travels far, evidently.
Yeah. Well, which brings me, I guess, maybe to our last topic, unless you want to talk about some other things, and that is your research. And that, as I mentioned, you are very data-driven, and to actually take on research is quite a task, because somebody's got to sit there and analyze the data. Yeah. And I'm sure you had some help, but tell us a little bit about, what drove you to get into the research. I know you mentioned it already, and tell us what some of the findings were. Your paper came out in 2022.
Yeah, we had two papers, one in 2022, one in 2023, about 4 or 5 months ago. The data originally was not for publication. That's not what the goal was. The goal was to look for trends and information that could improve patient care. We wanted the data so that we could know in-house the type of impact that we were having on the patient's health. We did want to have better conversations with payers to see if they were interested in this product, but that's a different story. They're not. But the data that we ended up publishing was, I guess we could thank or blame or whatever you want to say, Professor Tim Noakes. So I did a journal club for them. They were looking for somebody who wanted to do a journal club. So I did the journal club. So this was my initial coming out to the nutrition network, that I just wasn't some name and email address taking their courses. At that point, shortly after that, they announced that they were going to have their first medical practitioner certification class. And I had done all of their courses, so I threw my hat in the ring. Long story short, I got Professor Noakes as my mentor. And so we were doing this Buffalo to South Africa, and when he saw what we had, as far as data on close to 1,000 people, all the blood chemistry, all the biomarkers, the fitness assessments. He just basically demanded that that I publish this. And he said at that point, he says, Peter, I'll help you. I know this is not what you do, but I will help you. You will write it, but I will help you. And I met with Professor Noakes every week after I had graduated from the medical practitioner certification. I probably met with him every week for a little over 3 months. And I had my team with me. I had my staff, but I had to do all the writing. I have a partner, Dr. David Nichols. He's a family doctor. He's also a whiz with IT. It was David who actually helped create the data collection on our side, kept it HIPAA compliant, but also made it very easy for us to analyze the data. We hired a statistician to look at the data and provide it in a format that we could publish on. And we submitted it to, actually, I think I submitted it to the New England Journal of Medicine. Again, it was my call, and it made it past desk review. And Professor Noakes told me, Peter, this is going to get published in a top-tier journal if it made it past New England Journal of Medicine's desk review. And then it was picked up immediately by the American Journal of Preventive Medicine, and we published the large group, 536 patients that we had all data on, and the outcomes were impressive. I think we got to have a really good conversation regarding, as I mentioned, what we're talking about today, how a multidisciplinary approach, looking at stress, looking at sleep, looking at the proper diet, a therapeutic carb reduction in people that are metabolically unhealthy or dysfunctional, and exercise. And what that did to this large population of some people that just had metabolic syndrome, some that were pre-diabetic, many that were diabetic, and those were not only obese, but severely obese, and people that were not only diabetic, but out of control diabetic. And when you look at the big picture, every single surrogate marker of insulin resistance improved in this population. It didn't matter which population you looked at. Then the next paper, which we just came out in September in the same journal, the American Journal of Preventive Medicine, we wanted to show, because this is a big part of the conversation, as you know, is money. Is the cost savings of what happens to one of these diabetics when you actually reverse or put their diabetes in remission. And this patient, and I think this is why we chose this one patient, he was very diligent. We met him because he was doing 20,000 steps a day in the mall that we were located in. He had met with a dietitian that his primary care doctor had given him. His wife was the support in the dietary part of it, and his blood sugar was still 130 to 140 every morning on Janumet. And so that's for those people who don't know, that's 2 medications, Januvia and metformin, and he still could not control his blood sugar into normal ranges. And he was 45 or so pounds overweight, despite the exercise, but despite finding the structured diet, and he was like that for 12 years on these medications. He was also on multiple blood pressure meds. And within 6 weeks of adopting resistance training, I think, in this patient's case, and a therapeutic carbohydrate reduction, and only to about 50 to 80 grams a day, that's all it took to get him down there, he was able to get off all of his hypertensives and his glycemic control medications in 6 weeks. And I think next month it's 3 years, and he is still at 72 years old, not on those medications. And it was $8,800 in savings. So from a commercial payer, it kind of suggests to you what's really going on where a commercial payer wouldn't want this as part of their offerings. And there's a whole bunch going on, but that's why we identified the self-funded employer. They want that $8,800, and they want a healthier employee.
So in your research paper, you showed that you could deprescribe and save money. That's part of it all.
That's a big part of it. Yeah.
How satisfying to share your life's work in medical literature.
Yeah, I have to say it was a proud moment. But I don't know, Jeff. I tell people all the time, because they look at me and they say, "Well, you do what?" And then I say, "Yeah, I help people put diabetes in remission, and then I help other people make the world championships and win national championships." And I tell them that I get as much pleasure out of either one of those situations as I did publishing. But I have to say, as far as life work and someone who decided not to go into medicine and decided who technically to work in a gym for the rest of his life, to see that paper and to see those numbers and to understand what they really mean as far as not only cost savings, but also disease burden and quality of life in all of these people, it was a good moment. I look forward to doing more. While it's not my focus, we understand how to have that conversation, and we have a lot that we want to talk about. Polycystic ovarian syndrome is on our radar. Non-alcoholic fatty liver disease is on our radar. So if you're a provider out there and you would like to be involved in getting us patients and working on the protocol and defining it and getting something published on this, I would love to hear from you.
Well, Peter, I think you landed in the right spot, and we want to wish you the best in your future endeavors. And if I get my act together, we'll be sure to put the links to your papers on the YouTube and all the places that it needs to go.
I appreciate that. Yeah, I guess in the publishing world, citations are a big deal. So it's like, okay, well, I'm happy if somebody reads it. So
well, good for you, Peter. So how can our audience find out more about you?
You can go to restoremedicalfitness.com, and we've got a pretty decent website trying to explain how the remote program works. And we offer a free health risk consultation. So you can find our app. You can download the app once you fill out some basic information. And in that app, you automatically get access to booking that free health risk consultation. You can watch one of our educational videos about signs and symptoms. There's a lot of people that decide it's time to do something, and unfortunately, it may be time to call their doctor rather than me because they're being motivated by things that need to be looked at. I think that video is critically important. That's why we put it out for everyone, the signs and symptoms video. And then I believe there's 7 or 8 videos from testimonials from people that you may identify with, people that were having troubles reaching certain ages, certain disease states that were giving up hope and found our program and completely reversed their life. So you get all that when you download the video, and then we would love to have a conversation and try to listen to you. I think that's the important part about coaching that a lot of people don't realize is you really do. I mean, I know there's this patient-centered care in healthcare, but we really embrace that. We really want to have a conversation about what is important to the patient. What are their values? What are their goals? And what's going to motivate them to continue? And then we align the world-class best of care and deliver it to them and help them achieve their goal. And then, they thank us somewhere down the line like we did the work, but they do it all, but they get to achieve their goals. So we're excited. I'd love to hear from more patients.
Well, thanks again, Peter. And to our audience, be sure to subscribe to our YouTube channel at Low Carb Conferences to listen to more podcasts and also to our lecture series that is ongoing. So that's all for now. Thanks, Peter, and we'll talk soon.
Thanks, Jeff. Thanks for having me.